Hey, dude,
Hey, how's it going?
I gotta check something. Can you tell me if you're seeing this one?
Give me a second.
Hang on. That's not it.
The presenter review. Yep.
Okay. So this is hang on. Why is this thing not working? Jesus Christ. Hmm. Do you just see the PowerPoint? That's it, right?
Yeah, yeah, that's exactly what you want to see. Yeah.
All right, sounds good. I think Dr. O'Brien wants to start first. So
Yeah, that's what's gonna happen.
is that normally how it works?
Yeah,
All right. Excuse me. So I'm going to stop sharing.
you logged in early, I see, just to make sure everything
Yeah.
works.
Yeah, dude. Dude, did you save your ASAT for last, or did you like use up some of them this morning?
So I used one this morning, and since there's only 4 studies in the afternoon,
Yeah.
uh, one of them's an 8 set, one of them's a watch bat, so I'm
Yeah.
leaving those two for last, so we could go.
Yeah, I did only 4 studies, but they were like my hardest studies. Like retitration, they were not like fake retitration, they were actually serious retitration study.
Did 4 of my studies. It was titration, retitration,
Yeah,
titration, retitration. That's what I
yeah,
had
no, that,
today.
that's what really mine is. Titration, retitration. I'm pretty sure I could have done another study, but I had to get ready for this one. So I
Yeah,
couldn't do it. Yeah, but and then I have who do you have in the afternoon?
completion.
A police? Oh, so that's why you gotta be in the office.
Yep.
What do you guys go get for lunch?
We went to Sotai, that one place we went before.
Oh, for Thai food?
Yeah, it was really good.
Yeah, no, Thai
I
food.
got their I got their spiciest food. Like,
Yeah,
it was tasty.
yeah. All right, sounds good.
What's nice is all future people that watch this recording will know that Sotai is good and tasty.
Nobody's watching this recording.
I know. Yeah. My first, my first one in the afternoon was a negative PSG already, so I'm in luck.
Yeah. Yeah. Do you did you I haven't looked at the calendar yet, but when are we presenting our grand round? Is that May or something?
Here, I could pull it up real quick and tell you. 1 second.
Yeah. Well, what else we got resent left? After the journal club, just grand round, right?
Yep.
Yeah.
Uh, when was it sent to us? Just recently, right?
Yeah, just look for emails from Dr. Shawirkar. Wow, I don't know. Is tonight the weather supposed to be bad or something? Because like
Yeah, that's
schools are closing tonight, man.
yeah, that's what it was supposed to be.
Yeah.
It's pretty bad,
Is it
apparently.
really? Is it really that bad? We have how bad is it? You know, this isn't yeah.
Uh, well, right now it's not that bad.
Yeah, I don't even see any snow right now, so it can't be that bad.
I clicked on one, but it's not popping up the way I want it to be.
Hey, Dr. O'Brien, you are starting off first, right? Is that right?
Yes, I'll do about 10 or 12 minutes, maybe
All right.
15 at max, and then I'll hand it over to you.
That sounds good. All right.
All right, so what are we now? 1 minute. We'll give it another minute just to get people in.
Yeah, yeah.
I don't know if everybody's expected today or if some people are still in clinic or out.
Hello.
Hey, Dr. Shelby.
Hello. Yeah, I think giving it maybe just another minute or so would be great.
Yeah. So maybe till 1:03 and then I'll get started because I don't want to take the time away from the journal club. Okay, shall we make a start? And hopefully people will come in. So I am going to share my screen. Okay, can everybody see
Yep.
the page? Okay. All right, so we're going to be talking about relative risks and odds ratios. And stop me. I'm going to turn my sort of camera so I can't see everybody. And I'm not going to be watching the chat. So if you have questions, just stop me as we go through. So you will see relative risks and odds ratios a lot when you're reading articles or presenting articles. I think it's just important that you have like a basic understanding of what they are. So what they are measures of association. So basically how an exposure varies with an outcome. And the standard way to look at these is by a 2x2 table. So similar to what you see in the bottom corner there. This is going to be so helpful to you, this 2x2 table, as you go forward. So just keep that in mind. It's a really important, like 4 cells that you can use for lots of things. So the ways in which these associations between exposures and outcomes can be expressed are ratios. So we're going to talk about relative risk ratios and odds ratios. So the relative risk, known as the RR, is the individual likelihood of developing a disease or an outcome given that you've been exposed, divided by the likelihood of developing the disease or the outcome given that you have not been exposed. Okay, so the relative risk is a ratio of incidence, and that's an important concept. It's a ratio of incidence of disease in exposed and non-exposed. So if you think about your 2x2 table, you can do this for all sorts of studies or articles that you look at if you can get the raw data, even if the authors haven't presented it. You will make up a 2x2 table. So you have your exposure at the top on the left and your non-exposure underneath. Then you have your disease and your no disease along the top. And it's important that they go in this order because you can see these letters here, A, B, C, and D. Okay, if you mix up the order, then everything goes a bit wonky. And then obviously you've got your totals at the end. Okay, so When you work out a relative risk, basically you're looking at the risk of developing a disease if you've been exposed, which essentially is A, so here, I don't know if you can see my cursor, but it's A in the box on the left, over A plus B, which is essentially the total here, divided by the risk of developing the disease in the non-exposed, which is C over C plus D. Okay, so if you know this 2x2 table, how you set it up, all you have to do is remember formulas for calculating risks and odds ratios and other things, okay? So going forward, how you interpret the relative risk is pretty straightforward. If the relative risk is 1, it's the same, right? There's no association because the risk's the same in the exposed group as it is in the unexposed. If it's greater than 1, then it's a positive association. The risk in the exposed group is higher than the risk in the unexposed. Similarly, if it's less than 1, then it's a negative association. Your risk is less in your exposed group. So, potentially that could be a protective effect depending on what you're looking at. So let's walk through an example. So here's our 2x2 table, our A, B, C, D cells. In this case, we're going to look at the risk of developing hypertension if you were exposed or not exposed to sleep apnea. So we just plug in our numbers, how many people with OSA developed hypertension, which is 16, how many did not, which is 74, and then you can see the totals on the outside of the boxes. The relative risk formula is here, A over A plus B divided by C over C plus D. So we just plug in those numbers and we get 1.93. Okay, so what that tells us is it's a relative risk of 1.93, i.e. the risk of developing the disease, which in this case is hypertension, in our exposed, i.e. OSA group, is 1.93 times greater than the risk of developing the disease in the non-OSA group, okay? So remember, relative risk of 1 equal. So if we take away that 1, that equal likelihood, then we have what is the increased risk. So in this particular case, remember we had 1.93 was the risk, but if we take away that 1, which is your equality, you're left with 0.93. Multiply that by 100 to get a percentage, and it's 93%. So that 1.93 relative risk is exactly the same as saying people with OSA are 93% more likely to get hypertension than those without OSA. Okay, sounds straightforward, right? So here's a table. Remember, 1 is equally likely, so there's no increased risk. 1.5 relative risk is 1.5 times more likely, or 50% increased risk because we take away this 1. The same for 2, it's twice as likely, but it's 100% increased risk because 2 minus 1 is 1 times 100, and so forth, okay? But remember, your increased risk could also be negative, which actually means it's a decreased risk. So if our increased risk is 0.7, right, relative risk of 0.7, we take away that baseline equality of 1, then we times the result by 100, it's minus 30, right? So the exposed group in this case is 30% less likely to develop the disease, okay? So just to check that everybody's following, relative risk can be used in what type of study? Anybody want to have a go at that? Nobody wants to try. Remember, it's an incidence. So if it's an incidence,
Longitudinal.
exactly. Longitudinal perspective, you have to have time to develop the outcome of interest, right? So remember that relative, if you're looking at studies that have a time element to developing an outcome, it should be a relative risk calculation, not an odds ratio. I will tell you that many studies out there will use odds ratios, and there's kind of a reason that people do that. It's not the right thing to do, but people do it. So just keep aware, be aware when you're reading articles, it should be relative risk if it's got time element. So the odds ratio, this is a different measure, and this is a different way of thinking of things. It's the odds of exposure among the diseased group compared to the odds of exposure among the non-diseased group. Okay, so because when you're looking at case control studies, you're selecting people based on the outcome of interest. Remember before in our other, when we're looking at relative risk, we were selecting people based on exposure and following them to an outcome. This is the opposite. We're taking people with an outcome that we're interested in, and we're going back to see what they were exposed to. Okay, so in these kinds of studies, like case control studies, you cannot calculate an incidence. Therefore, we cannot use relative risk, right? So that's when we use odds ratio. So an odds, it's not a proportion, but it's the ratio of the number of ways an event can occur relative to the number of ways the event cannot occur. So there's the formula for odds, right? The probability that the event occurs divided by 1 minus that probability. So the example is 4 out of 10 people develop a disease. The proportion might be 40%, but an odds could be 4 out of 6, right? So the odds could be different from the other ways of looking at it. So back to our 2x2 table, exactly the same table here, A, B, C, and D. We've got our exposure, non-exposure, disease, and no disease. But remember, this time we're looking backwards. We're looking at, given the disease, let's look back to see what the odds of the exposure were. So that means we can still use this table, but we kind of flip the formulas around a little bit. So now for an odds ratio, we're looking at what ends up being AD divided by BC. Okay, so again, if you've got that 2x2 table, you can just figure this out pretty quickly. The interpretation is pretty much the same, right? If it's 1, it's no relation. If it's greater than 1, it's positive association. If it's negative, then it's a negative association. So here's an example, back to our tables. So this time we're going to do the different formula, use the same table, but different formula. We plug in our numbers and we get the number 4.5. So what does this mean? In this particular case, it means that the exposure, which was the alcohol abuse, this is a study of bone mass and alcohol abuse, that the exposure is positively related to the bone mass. Therefore, the interpretation is the odds of alcohol abuse are 4 times higher in the group that have low bone mass, right? So we've picked them with low bone mass. We've gone back to look at the alcohol abuse. And what we found is that the odds of alcohol abuse are 4.5 times higher in the people who had low bone mass. So in some cases, the odds ratio and the relative risk are pretty much the same. And though the 2 key things to think about is when this happens, they approach each other when the disease is rare, the duration of the disease is short. Cases and controls are representative of everybody with and without disease in the population from which they were drawn, right? So sometimes, you know, you need to have really good representation for these 2 things to come together. So here is an example. This is if the disease is infrequent, right? So in this case, we would expect that maybe these are very similar because this is an infrequent disease. So we can look at our 2x2 table again. We can see that the disease is pretty infrequent, right? If you're exposed, only 200 out of 10,000 people develop the disease. We can plug in our different formulas for relative risk and odds ratio, and we get pretty much the same answer. Okay, so it didn't really matter which one you chose, although you should always choose the right one for your study design. However, if your disease is not infrequent, as you can see in this 2x2 table, like half of the people exposed developed the disease, if you plug these numbers into the relative formulas, you get, you know, different answers. And so you can see here that the relative risk is 2, but the odds ratio is closer to 3. And so this is why I think a lot of people often choose an odds ratio because it gives them better results, right? So if they've done a longitudinal, like a prospective study, and they're using an odds ratio, the first thing I would think about is, oh, are they doing that because the odds ratio looks better for the publication than the relative risk? Because if there's an element of time, they should have used the relative risk. Okay, so another thing just to sort of bear in mind. So the 2x2 tables, don't worry about the messiness of this slide. The whole point of showing this is that 2x2 tables are super helpful for lots of things. Not only can you look at odds ratios and relative risk, you can also use different formulas with those same 2x2 tables of looking at sensitivity, specificity, positive and negative predictive values. So these 2x2 tables are super helpful to figure out a lot of different things. And so just to finish up with the confidence interval, because if we have our odds or our, you know, risk, then we want to understand, well, is it significant, right? Because just because it's increased or decreased does not necessarily mean to say that it's significant. So in this case, we use confidence intervals. So the confidence interval really gives us the level of uncertainty around that measure. So it's the precision essentially. So you will see when you see odds ratios like 2.6, you'll see the 95% confidence interval could be like 1.9 to 2.9, which is pretty tight, right? So that means that we're probably a pretty good estimate that we're about right. So also if it crosses 1, like in this case at the bottom, 0.9 to 1.1, that's a non-significant finding because it's crossed 1. Right? That both ends of your confidence interval either need to be above 1 or below 1, but don't cross it. If they cross it, it's not significant. Something else that this can tell you, you might have something that has like an odds ratio of 7.5 and think, wow, that's a really increased, odds, or if it was a risk ratio, risk of this outcome. But if you look at the confidence intervals and they go from like, 1.2 to 200 and something, you're like, well, hang on a minute, that's really not a very precise estimate, right? It could have been anywhere between 1.2 and 200. Just happens in this case that it was 7. So I'd be questioning those findings. I wouldn't really be putting much faith in the fact that it really was 7. So those tighter confidence intervals should give you more confidence that finding is a pretty reasonable estimate of the associations that you're looking at. And I think that is my last slide. So I will stop there and pass it on over for Journal Club.
All right, thank you. Let me share my slide. Can everyone see this slide's okay?
Yes.
All right, hi everyone. I'm T. I'm one of the sleep medicine fellow here. Today, we're going to talk about the article's title, Effects of High Intensity Interval Training on Sleep Disturbances Associated with Post-Traumatic Stress Disorder. The reason I picked this article is just because, I came from a military background, and one of my goal after graduating from this fellowship is actually to work with our veteran population in sleep medicine. So this is definitely something that's pertinent. And I think one of the things about a veteran population is that there's so many burden of PTSD or other psychiatric comorbidities that sometimes, the picture can get a little bit complicated when it comes to their sleep comorbidity management. So we're going to start off first with the background of why this study was being made. And so there have been several analyses in the past that found, PTSD patients have reduced sleep efficiency and total sleep time, as well as increased sleep disturbance. And the thought process behind that is that it's due to a traumatic event that can cause like neurobiological changes that then cause disruption in the modulation of arousal, causing them to have maladaptive emotional regulation, as well as, persistent hyperarousal from there. Obviously there are other meta-analyses as well that support the, effectiveness of exercises for reducing the PTSD severity and the increase of overall sleep quality. Some of the mechanisms just for the exercise benefit that I thought could be interesting, but supposedly they say that it's because of PTSD events is an actual acute stressor, whereas exercise itself is also an acute stressor. So they thought that maybe doing that often is kind of like a repeat exposure to where they would then have subsequent, hyperarousal because they're getting used to it. So therefore, subsequently, it improves, sleep quality. The other aspect is probably just, exercise certainly will reduce obesity as well as cardiorespiratory fitness. And because of the bidirectional benefits, it's by reducing obesity and improving the cardiorespiratory fitness, it is hopeful that it can be associated with reduced PTSD symptom and sleep disturbance. Now, I don't know whether I want to bring my thoughts here, especially to our colleagues with psychology background, what do they actually think about this repeat exposure that, just to the acute, stressor, and that's equivalent of exercise. Have you ever found, this to be very effective among our veteran population at all?
Guess I'm a token psychologist in the room here. So I mean, I'm a little bit skeptical of that hypothesis, just insofar as the nature of the stressors seems to me to be significantly different in terms of emotional valence.
Yeah.
When you expose yourself to exercise versus your repeated exposure through nightmares or re-experiencing kinds of
Yeah.
events through PTSD.
Yeah.
But that was my first reaction to that.
Yeah, for sure.
In the context of military folks with PTSD, I'm not sure that exercise is kind of a first line treatment. Certainly it's maybe an adjunctive treatment that may benefit overall, mental well-being and complement any evidence-based kind of treatment for PTSD.
Mm-hmm. All right. Well, thank you.
Any other psychologists, please correct me or add more.
Thanks, Dr. Arnott. I don't have anything more to add. I think there's benefits to exercise that aren't necessarily related to the PTSD events that can be indirectly helpful.
All right. That's thank you for your insights.
Well, what about the hypothesis that the high intensity exercise might be different from the I don't know what to call it, more spread out exercise?
Just in terms of exposure.
Yeah, would you have predicted, like I think they did, high intensity would work, but the other one wouldn't?
I don't know. I mean, I guess I get the theory a little bit, like that.
Yeah,
intensity is. Yeah,
I don't know how they actually come up with that, just because, so I was curious about that too, because they thought that high intensity would lead to less anxiety, which then subsequently could help with, PTSD, but I don't really know where the correlation is.
Is that, the high intensity workout increases the dopamine levels, like neurohormonal increase that causes some kind of reduction in their mood and behavioral changes? I'm not sure that they're not expressing that on this paper.
Okay. Well, thank you. So next, so from those thought, that was where this study was actually, created. It was that because of the overlap between the PTSD symptoms and anxiety, and they pull up some research that found that high intensity interval training can reduce anxiety. So their thought process that maybe by reducing the anxiety, they can subsequently reduce the sleep disturbance and improve the sleep quality in PTSD symptoms. So that's how they approach with this hypothesis, where they said that high intensity training reduces subjective and objective sleep disturbance compared with low intensity training in patients with PTSD. And then they did another sub-analysis where they pull a subgroup of individual with clinical significant sleep disturbance. And from their cutoff, they measure that as sleep efficiency under 85%. And from there, they then say that, with this very specialized group of people whom we're interested in, high intensity training compared with low intensity training will reduce subjective and objective sleep disturbance. So, one of the thing about this that I thought was a little bit interesting, and I wonder if, you guys have any thought that, why are we establishing a sleep efficiency, like cutoff of just, under 85%? And like, how is it, like when we look at the clinicals, sleep disturbed population, what kind of things we may see. Do you guys have any thoughts on that when you just look at that and think of why they do it that way? No?
In the sleep lab, they have all kinds of reasons to have low sleep efficiency. But I think most people just get a feel for what the range is and they say, oh, that's low compared to most of the studies I read, or that's high. So like for me, I would have said that that's an okay division line just based on reading studies, but I don't know.
I think, yeah.
I don't know if there's like a community study or something else.
Yeah.
that would tell me.
Yeah. I think, like they may just make this cutoff, I think for a very pertinent reason. I think that, like once we go through this study, I think it'll be more obvious. So let's continue on. So they actually did the study to where they do parallel group. And the Assessors of Lyme is randomized control trial where they, contact 137 people. And obviously, after meeting the inclusion exclusion criteria is where they finally get 40 people. And then they randomize it based on a randomization like a web-based like app to allocate 20 people to the high intensity training and then another 20 people to the low intensity training. One of the thing, like for the high intensity training, all 20 of them, like, finished the study where we were able to get, do all the analysis. And then even on the low intensity training, 19 of them complete with just one. So that was a very, interesting aspect too, like, and very impressive that, one of them just drop out. It is a longitudinal study somewhat. It doesn't, it wasn't very long, but that was something that I thought was, pretty interesting, to say the least. One little question I have, and maybe like I'm curious to hear what are the thoughts here, is that, what are some of the reasons for this study to be carried out in a parallel group assessor blind randomized control trial? Anyone? No? I think why they actually do that, maybe it's just to eliminate the bias. Just because like when you do that, and if the assessor like have an idea of what this study is for, what is the goal, there may have been a bias before analyzing data to where it could skew the result. All right. So the inclusion criteria include, obviously all the patients like have to have a PTSD diagnosis based on the DSM-5, and the minimum age is 18 years old. So from that aspect itself, so this is probably only generalizable for just adults. It does not apply to anyone under the age of 17 years or younger. In terms of the exclusion criteria, so, if you have a lifelong diagnosis of schizophrenia or bipolar 1, you cannot be in this study. If you have acute alcohol or substance addiction, you cannot be in this study, as well as acute suicidal ideation. Obviously, if you can't partake in the cardio training, you can't be in this study, and you have to be able to undergo more than 75 minutes of the cardio training or the yoga exercise per week in order to be in this study. And you have to undergo less than that. If you undergo more than that, you couldn't be in this study. And if you were undergoing trauma-focused psychotherapy, you couldn't be in this study. one of the things that I thought was a little bit interesting was that, why they suddenly just, exclude bipolar type 1 versus bipolar type 2. Does anyone have any thoughts on that?
Is it because possibly like bipolar 1 is often like severe, longer lasting and has mania associated to it, whereas type 2 is more hypomania, possibly?
Yeah, that could just be, so the hypomania itself. Maybe that's an interesting thought. Maybe the hypomania itself has some residual, I would say, is it? Yeah, so it may affect the results a little bit. I just don't know why. Right. No, that's interesting. Yeah.
Maybe they were doing their trial and they came along a patient that they didn't want to include, who had bipolar 1, and so they added that to their exclusion.
Okay. That could have been it. That could have been it.
I hate to say that, but that's how it can happen sometimes.
Okay. Obviously, these and the other ones are just basically something that, when somebody's in this acute state, they can't partake in this study, I think. All right. And I think for this one right here, for undergoing trauma-focused psychotherapy, they also want to make sure that, the benefit from exercise is actually, can be delineated from just the exercise, whether it's high intensity versus low intensity, and it's not confounded by potentially the trauma-focused psychotherapy. So that's the other one right there. Thank you. Okay. All right. So next one is how they do this is in term of implementation is that they split the patient into the high interval intensity group, where it was implemented on a bicycle ergometer, and the low intensity group is more where they focus more on flexibility as well as low intensity resistant exercise. So every training session has a 5 minutes warm up, as well as a 20 minutes high intensity session followed by a 5 minutes cool down. And each of those training session is going to have 1 minute interval where the maximum heart rate needs to be over 77%. And they do monitor that based from the pulse chest bell, as well. I think that's and as well as there's a fitness watch that they monitor that. So whenever the heart rate goes below 77%, the max is where they increase the intensity or the resistance of the bike, and so that the patient heart rate continues to be above that level. And they do this, 6 times for every 2 days within a 12-day period. And obviously, the low intensity group, the frequency and duration will match to the high interval intensity training protocol, including the warm up and the cool down. Instead of just being on the bike, they would just focus more on flexibility, low intensity resistant exercise, and heart rate is always kept below 70% of the heart rate maximum. Oh, did I? Okay. There's one aspect to here that I want to talk about for the data analysis. So what they actually do is they utilize, this statistics software that kind of used t-test as well as chi-square. The significant level was set at 0.05. It's a 210 for the baseline analysis. And they utilize, Bonferroni correction for all the linear multi-level modeling. And they set that as 0.01 for analyzing the objective sleep measure, and as well as 0.008 for analyzing the subjective sleep measure. This is actually something that I was reading about, and I didn't really know what it was until I looked it up. But does anyone have any idea what the Bonferroni correction happens to be?
Is it like an adjustment to the p-value or something like that? I think.
Yeah, no, absolutely. You are correct. So whenever you do a study, right, and if you analyze a lot of stuff within that, like a lot of factors for that study, chances are you're more likely to find something statistically significant. So obviously, if you measure more of that items, then the p-value need to be adjusted lower for it to have a statistical significance. So that was something that I learned out. That's very impressive, Omar, that you actually know what it is, right? So and then they measure what the intervention between the groups of the high intensity versus the low intensity group at 3 different times between the baseline, the intervention, as well as the post exercise. And the other thing that they then look at is they look at closely at the clinical significant sleep disturbance groups where they define as sleep efficiency under 85%. And I think one of the things why they might want to do that is just because, when we have our data and we don't have a lot of findings where they are statistical significant, then we focus more on the clinically relevant sample to see if there's any like very minor factors that is overshadowed when we include it into a bigger population. So just want to make sure that there's nothing that that we're missing. And also, I think the reason why they define the sleep efficiency under 85% because the population sample was only 40. Now, if they were actually to define that, under 70 or 65, obviously the sample group is going to get significantly lower. So we don't really have an opportunity to look at any of the data to, find what is, to make any sort of conclusion or some sort of thoughts that will be useful for like future study. When we're going to go back and look at how they actually just measure some of the things that they use to measure the data. Obviously, this is just, some of the national surveys or measurement, just for your own thoughts on how they actually do this. Wish you would see it more. And obviously, just the general picture from this slide is that it was a very comprehensive measurements of both objective as well as subjective factors for this study. Okay. So this is a sample characteristic of this study. Anybody just looking at this data right here find anything interesting that kind of stand out?
Obviously not a military population because it's predominantly women. But
Yeah, well, I don't know about that. That's what my first thought was. But I actually, when I was in the military, there's a lot of strong women there. So I think, the population is actually more closer to 50s. I would say it's 50-50, but I would say more like, maybe 40% women and maybe 60% like men in terms of the military population. So. Yeah, but that was one thing that stands out is that there were so many female participants in this study. So I wonder how that actually affects, what any conclusion we can draw. Do you think this is actually a positive or like a negative or weakness of this sample?
I mean, I would say it's a weakness because I would also want to have males that are also part of the study so that it doesn't generalize.
Yeah.
Doesn't make it.
Right. and it's kind of harder. I feel like it's kind of harder to talk to a male, I guess, like military veterans about this study when you just say that, well, the study was only, the majority of them were women. So they're like, well, this doesn't really apply to me, doc. Right? So that was one thing that, I thought also that stands out. Thank you for pointing that out. Okay. And this is the baseline characteristic for both the high intensity interval training group versus low intensity training group. And just from this slide itself, I mean, obviously, you can appreciate that, from the subjective sleep quality measurement, like there is a lot of factor that they go into this study, as well as the objective measurement as well, that we just kind of discussed prior. The one thing take home point from this study, at least from the baseline characteristic, is that, the participants to both the high intensity as well as the low intensity groups are very similar, where there isn't that much of a statistical difference in either group. And I think that helps the study a little bit. So we're kind of talking about, the result of the mixed model full sample. For the sake of this talk, we're not going to focus on what is the mixed model really mean. I think the take-home point from this study is that from the objective data, there isn't that much of any statistical significant p-value, whereas the only statistical significant p-value here is actually the Pittsburgh Sleep Quality Index, and that was 0.002. So patients in the high intensity training group felt that their sleep was better in comparison to those those that participate in the low intensity training group and how they feel. Okay. Next, we then take a look at because we didn't have a lot of statistical significant measurements for both the objective and the subjective data. We then look at the subsample where patients are have the sleep efficiency less than 85%, just so that we could look closer at these measurements and see if there's something else that may be found that we may be missing. Do you guys, kind of see anything that stands out in this table? Okay. So the one thing that actually, just from like the first, when I just look at it, the one thing that actually stand out was, we still have, the Pittsburgh Sleep Quality Index, where it's still statistically significant. Whereas, other subjective measurements are not statistically significant. But the weight after sleep is pretty profound as well. And I just don't know if this is something that is just an incidental finding, or is there something else that that maybe I'm missing? Do anybody have any idea or thoughts about this finding?
Maybe the exercisers are more tired, people who exercise higher. So
Okay.
less wake after sleep onset, but also the sample size really kind of, very small, like 24 people.
Mm-hmm.
Like it's hard to say like if the power is high enough to actually draw like true conclusions.
now since you brought into the the power calculation, surprisingly for a randomized control trial, they actually this study didn't really have any power calculation. It was so it was they actually for some reason turned it into a pilot study. And I just wonder, why they actually do it. Maybe it was cheaper to just actually do it in order to find if there's anything that could be relevant for a future study that could have, it's more robust to make any conclusion. And the other aspect that I wonder too is they only look for like a 24 days. And we'll talk more into the strength and weakness of this study a little.
Oh,
So,
T, what are you, going back to the last slide, are you just like trying to get whether people think a 6-minute difference is that impressive, or what are you asking?
no, this one right here, I just don't know, like this value right here, is this like an incidental finding or what to make
Oh,
it?
yeah.
To be honest.
Okay, I'm sorry. It's in a 16-minute, and then, yeah. Well, this is the thing. First of all, the p-value tells you how incidental or not it is. P 0.01, okay, maybe, but unlikely. P.001, very unlikely to be spurious, I think. But you could want, I thought you were wondering, oh, is that really that impressive? 16 is not a big difference. But on the other hand, to that, I'll just say that whenever you're looking at sleep architecture and you're giving an intervention for any kind of insomnia or related thing, small differences are the finding of the day. I mean, that's all these trials for hypnotics, other types, when they make a change in the objective numbers, it's small, and it's the subjective that actually turns out bigger. That's my overall, probably too broad brushstroke summary, but you can ask other people think that's typical.
Okay.
And
Thank
that's the difference in this study, right? I mean, the objective findings show that there was a difference in wake after sleep onset, but the subjective findings, patients did not notice a difference in wake after sleep onset, that it didn't make a difference for them. And actually their post 1 week after the exercise was, after the interventions were completed, was actually, they felt like they were awake longer than they were.
Yeah, no, yeah, that's I was just like, why did that happen as well? And that was just like a little bit kind of weird that people didn't feel like that it made like that much of a difference in terms of the amount of time that they stay awake after going back to sleep. Yeah. All right. So in terms of the strength and the limitation of this study, obviously it was very robust, in which it has multiple subjective and objective measurements over 24 nights to assess the different aspect of sleep quality. It was a longitudinal studies, and there was like minimal dropout, especially there was just only one in the low intensity group. The one thing that may be limited from the study was that there's no control group, and I think it's just because they're limited by the amount of people in the study. Obviously, if they have like they assign a group of people to the control group, they wouldn't have enough people from either arms of the high intensity versus a low intensity then to make any. They didn't feel that it would be helpful to make any conclusion that would be useful for future studies. Obviously, another aspect is that they only measure and track people over 24 days. But when in fact is that, a lot of, we know that the PTSD is more of a chronic symptoms. And sometimes it takes a little bit longer to see a difference. Where, and from what all the studies shows that even the marginal improvement are at the earliest notice is that 2 months to 4 months, and this certainly falls short of that as well. So with all these in mind, I wonder, do you guys feel that this actually affect the way you, does it change your clinical practice at all? Or, what do you guys think?
We always tell patients to, diet and exercise. I don't think it's going to change much. And a lot of the exercise ones, like, we know overall they have like benefit. The question is doing the studies for them sometimes are like, there wasn't enough people in the study. Like maybe if it had more, but it did show some significance, but not patient reported. And in the end, subjective is what matters to the patient.
Right. And so you kind of, but from your thought process, or do you value the patient, subjective belief that they're getting better? Because with the amount of, limited data we have only for like, less than a month, there isn't that much objective significant. But, is there any like significant impact that, the patient believe that they get better sleep and therefore they feel better? Do you feel like that affects your clinical practice at all?
I think it does. I think that's important for the patients to subjectively feel like they're getting better sleep, because that improves patient outcomes at the end of the day, right? When they come and see us and they think they're doing okay, as long as we're not seeing any objective evidence that they're doing poorly, then I think there's less problems in general. The worst patients are the ones that think they're doing really bad, and sometimes they're not objectively doing bad, or the ones that are, they feel like they're doing bad and there's objective evidence to kind of indicate that they are doing bad. Those patients tend to be more difficult. But the ones that think they're doing okay usually are easier patients to kind of manage from my limited experience.
And I would also wait to say, as a clinician myself, that the fact that they feel better means that, they're more motivated to keep going. And we do know that a lot of these objective measurement changes, they just don't happen over 24 days. Sometimes it takes a couple of months. But if they do feel better and they're more motivated to keep doing these, then I was, I would just encourage them to just do it, because it's it's not whether they're what matters that they do it and they continue to do that, and that's when you can start seeing the objective measurement, which takes a little bit longer to find, right?
I had a quick question. When you're talking about feeling better, which variable are you talking about?
I'm actually talking about this this variable right here, where the Pittsburgh Sleep Quality Index.
Right. So I'm wondering about that too, because it's a pretty broad measure. It's measuring other things. I mean, I didn't look at, it says global score, so I'm assuming it's like breathing and sweating at night and restlessness. And I'm wondering, I'd love to look at the different subsets of that particular survey and how those changed, or whether maybe the participants lost weight, or did we have any information on that?
Oh no, we didn't have any information on like the changes in weight. Okay. And that is the conclusion of my journal club. Is there any other question that people may have?
Great job, T. I think there were some things that came up along the way in the chat, but I think then they were subsequently answered later.
Oh, really?
Yeah.
I
So, I think
apologize.
you covered. Yeah, no, you're good. So I don't know if anyone has anything additional to add. I don't see any other hands up.
Oh, good job. And before time as well. I'm impressed.
All right. Well, thank you.
Yeah. Thank you both.
Good job.
Yeah, take care.
Thanks.